Hello everyone and welcome to our module on endometrial disorders. Let's start by briefly discussing the structure of the uterus. The uterus has an outer layer called the serosa, and then the middle layer of the uterus is called the myometrium, and this layer consists of smooth muscle. And then the innermost layer of the uterus, the layer that lines the uterine cavity, is called the endometrium. This is the mucosal surface of the uterus. It consists of glands which can secrete mucus and also stroma, which is connective tissue of the endometrial layer. And here's a drawing of the glands and stroma of the endometrium. The white spaces are the glands. They're lined by columnar epithelium, and the stroma is the connective tissue between the glands. And the glands and stroma grow during the course of the menstrual cycle. In the first half of the menstrual cycle, estrogen causes an increase in the number of glands and the number of stroma cells so that the endometrial layer grows in size. So as I just alluded to, the endometrium goes through growth and shedding as part of each menstrual cycle, and this is driven by hormones. Estrogen stimulates growth of those glands and stroma, and progesterone switches over from a growth phase to a secretory phase where the endometrium begins secreting mucus. And when progesterone is withdrawn, then the endometrium is shed, and this is what leads to menstruation. And here's a picture and drawing like you can find in most of your textbooks showing the hormone fluctuations during the menstrual cycle and what those hormones do to the endometrium. So in the first half of the menstrual cycle, the major hormone is estradiol produced by the ovaries. The level of estradiol, which is an estrogen, slowly rises during the first half of the menstrual cycle. This causes the glands and stroma to increase in size, and you can see that these glands in this drawing are becoming longer and deeper. That's typical of the first half of the menstrual cycle. In the second half of the menstrual cycle, the dominant hormone is progesterone, shown by this green line. Progesterone opposes the actions of estrogen, so there's less growth in size. The main change here is that the endometrium begins secreting mucus during the second half of the menstrual cycle. And then when progesterone levels fall, as shown by this green line declining here, that's what leads to menstruation. And that first half of the menstrual cycle is called the proliferative phase. This is driven by estrogen. This is where you see an increase in the number and size of the glands and stroma. The second half is called the secretory phase. This is progesterone driven. In this portion of the menstrual cycle, there's less proliferation, but secretory vacuoles appear, there are prominent spiral arterioles, and all of these changes are designed to prepare the uterus for possible pregnancy. So now that we've talked about the endometrium, we can begin to talk about endometrial disorders, and I'll start by discussing abnormal uterine bleeding. This refers to abnormal quantity, duration, or schedule of menstrual bleeding. Basically, women with heavy or irregular periods are said to have abnormal uterine bleeding. And sometimes abnormal uterine bleeding is subdivided into heavy menstrual bleeding and intermenstrual bleeding. Women with heavy menstrual bleeding have heavy or prolonged periods, and women with intermenstrual bleeding have irregular periods. And abnormal uterine bleeding is a very common gynecologic problem. Many women are referred to gynecologists for abnormal uterine bleeding. And the causes are classically remembered by the mnemonic palm coin, which I've written on the slide here. So let's go through each of these one at a time. The first cause of abnormal uterine bleeding is uterine polyps, which I'll talk about later in this video. Adenomyosis is the presence of endometrial glands in the myometrium, and I talk about this in the video on endometriosis. A leiomyoma is a smooth muscle tumor, also called a uterine fibroid, and I talk about this in the video on endometrial cancer. Other endometrial malignancies, as well as endometrial hyperplasia, can also cause uterine bleeding. Women who are coagulopathic, meaning they have some deficiency of clotting factors, can present with abnormal uterine bleeding. And then if ovulation is abnormal, women can have abnormal uterine bleeding. And a classic ovulatory disorder that causes uterine bleeding is an anovulatory cycle, which I'll talk about in just a minute. Endometrial causes refers to local problems in the endometrium that lead to uterine bleeding. Basically, it's a catch-all term. If women have none of the other causes on this slide, they are often presumed to have some local cause in their endometrium that leads to abnormal uterine bleeding. There are iatrogenic causes of uterine bleeding, things like intrauterine devices or drugs that disrupt the ovulatory cycle or inhibit coagulation and can therefore cause uterine bleeding. And then finally, NOS is not otherwise specified. This refers to very rare causes of abnormal uterine bleeding. For example, women can develop AV malformations in rare cases, and that can lead to uterine bleeding. So let's talk about an anovulatory cycle. This is a menstrual cycle without ovulation, and when there's no ovulation, there's no corpus luteum formation. Remember, the corpus luteum is a temporary endocrine structure that forms each menstrual cycle, and its job is to secrete progesterone. So when there's no ovulation and no corpus luteum formation, this means there will be no luteal phase of the ovary and no switch in the ovary from estrogen to progesterone secretion. As a result, the endometrium will undergo excessive growth from estrogen stimulation, And this growth is excessive because it is called unopposed, meaning there's no progesterone to oppose the estrogen effect. So the uterine lining just keeps growing and growing, and it sheds irregularly, and this leads to irregular bleeding. So why would a woman have an anovulatory cycle? Well, these are very common at menarche. At the start of puberty, there's an underdeveloped hypothalamus pituitary ovarian axis, and women will often have an anovulatory cycle, and they will begin menstruating with an irregular pattern. This is also common approaching menopause. At menopause, the ovaries have run out of eggs, so there's a loss of ovulation, but sometimes the ovaries still continue to produce estrogen, so you get anovulatory cycles. In addition, you can also see anovulatory cycles from other disorders. These can occur in the setting of thyroid disease. They're also common in women who are obese. Fatty tissue can produce estrogen, and this can disrupt the hypothalamus pituitary ovary axis, and that can also lead to anovulatory cycles, and anovulatory cycles for any reason will lead to dysfunctional uterine bleeding. Moving on, our next disorder is endometritis. This is inflammation of the endometrium, and there are generally two types. The first type is called acute or pregnancy-related, and the second type is called chronic or non-pregnancy-related. And on a biopsy specimen of the endometrium, the classic finding is to see neutrophils and inflammatory cells filling up the endometrial layer. The acute form, which is also called pregnancy-related endometritis, occurs postpartum. This is caused by bacterial infection after delivery or miscarriage, and a major risk factor is a cesarean section delivery. In a cesarean section, the surgeon will put his or her hands into the uterus, and you can imagine that it's easy to introduce bacteria. Because of this, prophylactic antibiotics are usually given before C-section, and when this occurs, it's an entire uterus disorder. It often also involves the myometrium, which is called metritis, and the woman will develop fever, abdominal pain, and uterine tenderness. It's usually diagnosed clinically based on these findings. The infections in acute endometritis tend to be polymicrobial. It's unlikely the boards will ask you to identify the causative agent because just about any bacteria can be involved, including all of the bacteria I've listed on the slide here. So for this reason, broad-spectrum antibiotics are usually used. The classic regimen is clindamycin plus gentamicin. This yields cure rates greater than 90%. An alternative is ampicillin and sulbactam. And I talk about all these antibiotics in the infectious disease section. A related disorder that can occur after a pregnancy is called retained products of conception. In this disorder, placental or fetal tissue remains behind in the uterus. This can occur after delivery or after a miscarriage. This will lead to uterine bleeding and pelvic pain, and then the tissue becomes necrotic, and it's prone to infection by flora from the cervix or vagina, and therefore this can lead to acute endometritis. It's usually diagnosed by history and also sometimes imaging, and the treatment is with antibiotics and surgery. For the chronic form of endometritis, there are three major causes. The first one is an intrauterine device, or IUD. Women sometimes use these for birth control, and they can lead to chronic inflammation in the uterus. Second cause is pelvic inflammatory disease. This is an ascending infection that may involve the uterus, fallopian tubes, and even ovaries. Therefore, pelvic inflammatory disease includes salpingitis, which is inflammation of the fallopian tubes, oophorytis, which is inflammation of the ovaries, and also endometritis. It's usually caused by chlamydia or gonorrhea, sexually transmitted bacteria, and the treatment is with antibiotics. And then finally, tuberculosis can rarely cause chronic inflammation in the uterus. This can spread hematogenously from the lungs, and this is identified on biopsy by finding acid-fast bacilli. Chronic endometritis is associated with infertility. You can imagine that it will be difficult for an embryo to implant in the uterine lining if there is chronic inflammation, and this is sometimes an indication for a biopsy. If a woman is infertile and it's not known why, a biopsy of her endometrium will be done, and the pathologist will be asked to see if there is evidence of chronic endometritis. In this circumstance, the hallmark of chronic endometritis on biopsy is the presence of a plasma cell. The reason for this is that white blood cells are a normal finding in the endometrium, but plasma cells are not. So if a plasma cell is seen, that indicates chronic inflammation. Our last disorder for this video is endometrial polyps. These polyps are caused by hyperplasia of the endometrial glands and stroma. Most of the time, 95%, they are benign, but rarely they can be malignant. And they grow outward from the endometrium, therefore they are called exophytic masses, as opposed to masses that tend to embed within the endometrial layer. They're often asymptomatic, but they can cause painless uterine bleeding, and when they're discovered, they're usually removed surgically for a couple of reasons. First of all, to stop the bleeding, second, to prevent infection, and third, as I said before, there's a small chance of malignancy. When these polyps are removed and examined under the microscope on histology, what you see are endometrial stroma and glands, and I've bolded the word stroma because it's thought that the stroma in these polyps is neoplastic and that the glands are just reactive and sort of brought along for the ride. You can also sometimes see smooth muscle. And these polyps are associated with unopposed estrogen, and that's not hard to remember because, as we talked about before, estrogen normally drives growth of the endometrium during the menstrual cycle, so obviously it can also drive growth of these polyps. And they are common in women who are approaching menopause because as women approach menopause, the ovaries continue to produce estrogen, but the ovaries develop chronic anovulation, and therefore there's a lack of progesterone. And so this can drive formation of polyps. And if you want to remember only one thing about endometrial polyps for the Step 1 exam, remember that they are associated with the drug tamoxifen. This is incredibly high yield. Tamoxifen is a selective estrogen receptor modulator, or SERM. It's a competitive antagonist of the breast estrogen receptor, and therefore it's used in ER-positive breast cancer. And I talk about this in videos on cancer drugs in the hematology section. But the thing you need to remember about tamoxifen is that although it blocks estrogen receptors in breast tissue, it's an agonist of estrogen receptors in other tissues like the bones and the uterus. What this means is tamoxifen functions as a partial agonist to the endometrium. This can cause the endometrial layer to proliferate, this can lead to hyperplasia, and it commonly leads to polyp formation. Up to a third of women taking tamoxifen will develop endometrial polyps, and that's why it's very high yield to remember this association. In addition, it can potentially lead to endometrial cancer, and once again, this is because of estrogen effects on the uterus. And that concludes our video on endometrial disorders.